I began finding people that were coming in with a consistent set of symptoms that was complicated. They were presenting with these complex neurological problems and neck pain and headaches. So, we have a consistent group of people that were coming in who were dizzy, who had consistent headaches, suboccipital headaches. They were having ocular forms of visual change, so like ocular migraines. They were having trouble tracking things. They were having, things like apnea at night, and problems with their sleep, sleep disturbances. They were getting very, very, very frequently, almost every single person was having some form of dizziness, vertigo, brain fog, sort of this like feeling of pressure in their head. And most of these cases stemmed from either them being a patient who had some form of hypermobile spectrum disorder like Ehlers-Danlos syndrome, where their bodies are producing too much of a type of collagen that gives them too much elasticity and not enough tensile strength. So like you can think of EDS people being the opposite of a steel cable, super bendy but doesn't hold a lot of load. Or these people were having that had some form of upper cervical injury, like a car accident or a combination thereof, really. I mean, what we typically see are these slightly hypermobile people that have had, recurrent MVAs, like motor vehicle accidents and things like this. So after, several years of consistently seeing these people, I think, as most practitioners, you tend to be curious about things that you see regularly. And I'm one of those people that when I start to see things over and over again, I just begin to do my research and work diligently trying to find an answer to sort of find a home for these people and a care plan that can work. And when I was in my fellowship, I spent a lot of time learning how to inject on necks. Probably the first 400 necks I injected, I did without any guidance. It was just blind injections, which isn't the greatest thing. And as I got more proficient with ultrasound, I began to spend a lot of time just scanning the cervical spine. And based off of my palpation-based sort of classic dextrose prolotherapy injection background, and then I started combining that with the image guidance, the ultrasound image guidance, and I sort of got to this point where I perfected a way of injecting cervical spines specifically to people that have this condition that's cranial cervical instability. So what CCI is laxity, typically in the upper couple of vertebrae in the neck, usually at the C1-2 level, so between the first and the second vertebrae. Occasionally it's C01, but I've only seen a handful of those cases. I do have one right now I'm managing. But the C1-2 is a complicated bone structure in the body. It's very unique. It has C1 is like a steering wheel that sits on a pinion, and it spins on that pinion. And there are a bunch of ligaments that hold this basically this ring onto this pinion. And if any of those ligaments are damaged, it creates a situation where that first vertebrae is moving dramatically more than it should. And if you understand that there's a spinal cord sitting right in that area, when that vertebrae begins to move too much, you literally get some form of impingement, compression, or vascular change on CSF flow around the brainstem, because the brainstem is right there. So cranial cervical instability then is instability in the upper cervical spine that affects the brainstem. And when the brainstem is affronted, if it's, pissed off, for lack of a better word, by this hypermobility or gross mobility on the upper cervical spine, and you irritate that brainstem, you get, headache. But the underlying root cause is typically some form of cranial cervical instability, which is that laxity in C1-2. So, putting it all together, because I'm one of the guys in the city that's actually interested in this, and I'm skilled enough with a needle to inject spine, and also I'm not shy about it. I don't have any quandary whatsoever about placing a needle a couple millimeters from somebody's spine or spinal cord or dura. It's very, actually enjoy it. And I just did more and more and more of them. And to be frank, I self-taught most of what I learned. I think I pioneered a few techniques along the way. For example, this morning, very, very well-known colleague of mine, he's the ex-president of the American Academy of Orthopedic Medicine. He's world famous interventional regenerative orthopedist Brian Scheipel asked me to teach him how to do ultrasound guided injections on C0, C12. So I've gotten to this point in my career where I'm not only injecting for cranial cervical instability, but I'm also teaching thought leaders in the industry and some of the old guard how to do this. So, without using X-ray guided injections, we are treating cranial cervical instability. We treat C01, C12, the full spine. We treat all the ligaments, all the muscles, all their origins and insertions. We hydrodissect out complex nerves that are associated with this condition. So our treatment paradigms then are to perform extremely precise guided interventional injections specific to areas of the spine that have damage and ligament laxity. And in the injectate that we use, we are able to tighten up, restore, or heal some of the damage to the ligaments, the capsules, and create stability out of instability. So that's our main goal and focus. We use what's called orthobiologics, which is things like PRP or platelet releasate or platelet-rich fibrinogen, or these things that are safer to use near structures that aren't going to harm someone. So in the PRP itself, PRP is a platelet-rich plasma. It's essentially taking whole blood through a centrifugal process, or so centrifugation of the whole blood. We are able to isolate out cells that we want, or cell like platelets. We're able to isolate out these platelets from whole blood and concentrate them very, very highly. And once they're concentrated, platelets contain growth factors and other things that help repair, remodeling, restoration of tissue, anti-inflammatory properties, and tend to heal things. So, for example, if somebody has gross laxity in their upper cervical spine and we're able to put some PRP into and around the joints and the ligaments and the tendons in this area, we can help the body heal and restore those damaged areas. Dextrose prolotherapy is awesome for people with hypermobility. So anyone with EDS or hypermobile spectrum disorders, dextrose prolotherapy is a fantastic treatment. It has the potential to create shortening and tightening and more robust collagen. In other words, if somebody has very lax, very loose, very stretchy, rubber bandy like ligaments, and you can inject something in there that tightens that up and creates more, basically creates stability out of instability, then that's going to be awesome for them. They're going to have less pain, less symptoms. So, but the problem with dextrose prolotherapy is that it classically has anesthetic in it. And so we try to avoid using anesthetic near C01, C12. At the end of the day, or at the end of the month, or the end of 6 months, PRP is going to do better than dextrose prolo will. However, you can do enough dextrose prolo to get to PRP. You have to use a lot more injections.